Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy that you chose to spend some time with us today, and we think that our conversation today will be very helpful. Without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Thank you so much, Dr. Neighbor, Dr. Waltz, and Dr. Hines, and Simon for being here. We have a major concern that one of our heroes has passed the bar, Dr. Wilbur Jordan, and I'd like to invite our co-moderators and our resident pastor to have a few brief words to say after Simon plays this video, please. Next verse you'll hear will be from Pastor Pointer after the video. Simon?
When Great Trees Fall by Maya Angelou. When great trees fall, rocks on distant hills shudder, lions hunker down in tall grasses, and even elephants lumber after safety. When great trees fall in forests, small things recoil into silence, their senses eroded beyond fear. When great souls die, the air around us becomes light, rare, sterile. We breathe briefly, our eyes briefly, see with a hurtful clarity. Our memory suddenly sharpened, examines, gnaws of kind words, unsaid, promised walks, never taken. Great souls die, and our reality, bound to them, takes leave of us. Our souls, dependent upon their nurture, now shrink, wizened. Our minds, formed and informed by their radiance, fall away. We are not so much maddened as reduced to the unutterable ignorance of dark, cold caves. And when great souls die, after a period, peace blooms. So slowly and always irregularly, space is filled with a kind of soothing electric vibration. Our senses restored, never to be the same. Whisper to us, they existed. They existed. We can be, and be better, for they existed. This is a poem that Maya Angelou actually wrote for Dr. King, who on this date was assassinated April 4th. In it, she's showing that it really doesn't matter how strong you are as a person. There is someone that influences you. And when that person that you have been influenced dies, it takes something out of you. But it's because of them that we can go on. When Dr. King was assassinated, Maya Angelou was so affected that it took a while for her to actually to get back to herself, and she
Pastor Pointer?
Thank you, Dr. Maxey. Certainly the last conversation I had the privilege of having with Dr. Jordan at length, I really queried him as to when he thought would be a good time to retire. And he never even paused to think about the question. He said, retire, I can't retire. If I retire, there'll be nobody who will take care of my patients and in the loving, caring way that I see about them. He said, so I don't know. I thought about it on a few occasions, but I look around and I don't see where God is letting me have a way out. And those of you who know, who knew Dr. Jordan knew above all that he was a believer. So if at all possible, I want to share this passage out of the Psalms. I spend a lot of time in the Psalms, and I find their refuge. Oh, Master, you have been our abode in every generation. Before mountains were born, before you spawned earth and world, from forever to forever, you are God. You bring man back to the dust and say, turn back, humankind. For 1,000 years in your eyes are like yesterday gone, like watching the night. You engulf them with sleep. In the morning, they are like grass that passes. In the morning, it sprouts and passes, but evening, it withers and dies. For we are consumed in your wrath, and in your fury we are dismayed. You set our transgressions before you, our hidden faults in the light of your face. For all our days slip away in your anger. We consume our years like a sigh. The days of our years are but 70 years. And if in great strength, 80 years, and their pride is trouble and grief. For we are swiftly cut down, we fly off. We can know the strength of your warmth, as the fear of you is your anger. To count our days rightly, instruct us, that we may get a heart of wisdom. Come back, O Lord, how long? And have pity on your servants. Sate us in the morn with your kindness. Let us sing and rejoice all our days. Give us joy in the days you afflicted us, the years we saw evil. Let your acts be seen by your servants, and your glory by their children. And may the sweetness of the Master our God be upon us, and the work of our hands firmly found for us, and the work of our hands firmly found. This passage I selected because it so rightly represents the life and work of Dr. Jordan, who was an infectious disease expert and who had no fear in facing the greatest infection disease of the latter 20th century that we commonly know as HIV and AIDS. And thank God for the life of our friend, our brother, our colleague. And now that he sleeps with the ancestors, we await that great sound of the trumpets blast, when we shall all be called to account and to rule and reign with Christ our Savior. And I trust that today, though our hearts are heavy, we know that he is merely sleeping, and that we too, if Christ tarries, will sleep. And then at the resurrection, we shall all be gathered at the seat of God's mercy. And there will be no more goodbyes. The sun will have no place there. God's own countenance shall light the city. And there shall be no death, no weeping, no gnashing of teeth. And we shall spend eternity thanking and praising God the Magnificent. Dr. Maxey.
Thank you, Pastor. We have a great program for you today. I'd like to recognize out of respect my co-moderators for a very brief word. We're dedicating this program to the memory of our great friend and advisory board member, Dr. Wilbur Jordan. So Dr. Neighbor Stevens, Dr. Walks, and Dr. Hines, and then we'll get to Dr. Lawson and Dr. Ed Chapman for our program.
Thank you, Dr. Maxey. There are many phases of Dr. Jordan's life that were great and are remembered and will be elevated, I'm sure, in the memorials that will be held in tribute to him. But I'd like to elevate one that is something that is very close to my heart and something that I work very hard on today. Dr. Jordan was a mentor. Dr. Jordan was a forerunner for those of us who went to Harvard and were in the Boston community. Dr. Jordan broke some important ground, and he has always been available to students, whether they came from the HBCUs to the summer program, or whether it was in NMA or SNMA, wherever. And certainly I wasn't there, but from what I've heard, he was a light there in the LA medical community. So I'd like to elevate and remember him for the work he did with bringing the younger ones along, and hold him up as an example to those of us who are still here and need to continue working as hard or hard as he did to help bring the younger ones along.
Thank you. Dr. Walks?
Dr. Maxey, I did not know Dr. Jordan as long as probably most of the people on this call right now, but I remember coming up and the old folks would say, "Show me your friends and I'll tell you who you are." And I think it's appropriate to carry that sentiment to any remembrance of Dr. Jordan. I don't think I've met anyone of any substance that didn't know Dr. Jordan. I was talking with Dr. Reed Tuckson this week, and I said, "Did you know Wilbur Jordan? He passed away this week." And Reed said, "Wilbur Jordan? Of course I know Wilbur Jordan." And I think when I look around at the people that have known Dr. Jordan for a long time, folks that have worked with him and respect not only the work he did, but the way he did it. Show me your friends and I'll tell you who you are. We can tell a lot about Dr. Jordan by the people who remember him and who will miss him. And I like to count myself in that number of people who will remember him and who will miss him. Thank you, Dr. Maxey.
Thank you. Is Dr. Hines on?
Dr. Hines is not on.
Okay, so we'll move to our program. I'd just like to say that when I went to interview for my internship, being recruited by the Boston Recruitment Council that was formed by Dr. Richard Williams and Dr. Vivian Penn, my interviewer was no other than Wilbur Jordan at Beth Israel Hospital in Boston, and he's been a friend ever since. But let's get to our program, which we're going to dedicate to him.
Dr. Maxey, Dr. Williams, who you just mentioned, is on. I don't know if you would care to give Dr. Williams a word.
Dr. Richard Williams, would you give a brief word before we get to our program?
Yes. Hello, everyone.
Hello.
I just want to follow up with a couple of remarks, particularly about Dr. Wilbur Jordan, who is, as was said, everybody who is anybody knew. I'd like to make a claim. I discovered Dr. Wilbur Jordan, and let me explain what that means. Dr. Maxey referred to the time when he was interviewed by the Central Recruitment Council of Boston Hospitals, which I established back in 1968 to try to recruit some Black folks for the Harvard hospitals. And so I started that recruitment council. One of the first people that we interviewed was the person who interviewed Dr. Maxey, and that was Dr. Wilbur Jordan. So Dr. Jordan came in as a student from Case Western University, where he had been studying and was a roommate, by the way, of Dr. David Satcher at that time. And so here comes this kind of gangly, farm-talking young man from Arkansas originally. And I was the first person to interview him for this new program that we'd established to try to bring some Black folks into Harvard. And to be quite honest with you, when I first talked with him, I said to myself, I'm not so sure that this guy is going to fit into our program. But the more I thought about it, the more I realized that we needed some folks to break new ground who spoke a bit differently than all of those highfalutin folks in Boston and at Harvard, and who had a different perspective on health, as he described to me. And so it was. We did recruit him. He came into Beth Israel Hospital as an intern. One of the first, he was one of the first interns, Black interns, in any of the Harvard hospitals. Subsequent to that, I also found out that Dr. Jordan was the descendant of a voodoo priestess in Arkansas. I don't know how many people know about that, but that had a tremendous impact on the way that he practiced medicine and his thinking in medicine. His grandmother was a voodoo priestess. And once I found out that and talked to him further, I was writing the textbook of Black-related diseases at that time, and I wanted to have something different from all of the white perspectives that were reflected in other textbooks of medicine. So I subsequently recruited him to write a chapter on voodoo medicine in the textbook of Black-related diseases. And so it was to be. He wrote this fantastic chapter, which you can view in that 1975 publication. And it was the first time that anything about voodoo had ever been reflected in the medical literature. And so that's Dr. Wilbur Jordan for you, a real true trailblazer and also a hellraiser. Thank you.
Thank you so much. I'd like to invite Dr. William Lawson and Dr. Edwin Chapman to the floor. And by executive order, I'm going to extend the program to have their complete presentation. Dr. Lawson, Dr. Chapman.
Go ahead.
Gentlemen.
Dr. Chapman is still on mute. Dr. Maxey, he looks like he's working diligently to hit that button and have the computer respond.
So in the meantime, let me introduce him. Dr. William Lawson is the former chair of psychiatry at Howard University and currently is professor of psychiatry at George Washington University School of Medicine. Dr. Chapman is an internal medicine specialist and also a specialist in drug addiction medicine in the Washington, D.C. area. He's testified before the U.S. Congress on several occasions, and we'd like to give the floor to them.
Okay. Simon, can we help get Dr. Chapman unmuted? There you go.
Hi, I was going to let Dr. Lawson go first. I'm in at the University of Maryland, and there's a lot of background noise. I was just trying to let that background noise die out. So if we let Dr. Lawson go first, I think you'll be trying to a little better here.
All right, Dr. Lawson, you're in the process of getting your screen up for us. Thank you, sir.
Yeah, is it on? Some reason it's not.
We can see your screen.
Gotcha. Okay, and then you see the slides.
And now if you click full screen on your slides, then we should be able to see them a little bit better.
Right. Full screen. Okay, don't see it. Okay, still don't see it.
Did you want to go to slideshow?
Yeah, that may be the best bet.
Right there.
Yeah, got you.
Okay.
But that is not the right slide. Yeah, it's not. Yeah, what I did is not moving. Not sure why. There we go. Okay, what you see now is a picture of me, and just want to note that I knew Dr. Jordan unusual circumstances. I was not a physician at the time. I was a psychologist, but we ended up on a panel together, and he helped introduce me to HIV, and also I think it was the influence in my actually going into medicine and in getting the Association of Black Psychologists focusing on HIV as an issue. I'll just go into substance abuse, which is a major problem. Dr. Chaplin has done an excellent job discussing the impact. Just want to note a few points that is associated with a lot of preventable deaths. That this is a slide that's been shown repeatedly, showing that during the COVID pandemic, there was a substantial increase in terms of overdose deaths, both in terms of prescribed opioids as well as illicit drugs as well. So there's been some focus on physicians' involvement in this, but the important point to note is that it didn't matter if it was abused drugs that were gotten on the street or abused drugs that were prescribed. I think both factors were important in terms of the overdose deaths. Locally, there were a number of overdose deaths in Washington, D.C. Greatest risk related to the synthetic opioids, fentanyl. I think Dr. Chapman will say more about that, as well as the usual heroin-related deaths. The important thing is that drug abuse has been associated not only with addiction, but also with a number of social problems: homelessness, crime, the proposed epidemic of violence, problems in terms of access to healthcare, productivity, accidents, as well as some general medical conditions such as AIDS, cancer, as well as having a role in mental illness. And the part of mental illness, I think, is related to one of the consequences of the COVID epidemic, and that is that individuals had to face challenges that were stressful, overwhelming, and caused depression, anxiety, and in many cases, frank PTSD, post-traumatic stress disorder symptoms that you had previously seen in combat veterans. And it's a special problem because, especially in our community, we find that mental disorders are often underdiagnosed, as in the case of depression, bipolar disorder, post-traumatic stress disorder, or overdiagnosed in such disorders such as schizophrenia. And the big problem is that when these co-occur together, when the same person has a substance abuse problem as well as a mental problem. So comorbidity refers to the fact that a person can have a mental disorder and an alcohol or drug abuse disorder. And why do they occur together? It's not that one caused the other, but sometimes it's hard to figure out which is the chicken and which is the egg. And we know that there are a number of risk factors that contribute to them occurring together. And I just want to emphasize one, which is stress. I'm well aware of the issue that's discussed previously of the problem of systemic racism contributing to ongoing stress, especially when we had the problems such as the COVID epidemic. The evidence is strong that people with mental disorders find that drug use and substance use can contribute to the mental disorder itself. People will use them for self-medication when there are no other options. And also it may change the way in which the brain works so that the addiction becomes more viable. On the other hand, it's well known that substance abuse disorders can contribute to psychiatric symptoms, mental disorders, and not just acutely producing behavior that is unacceptable, but also I and others have demonstrated that people who have early substance abuse use are much more likely to develop a mental disorder later in life. The big problem is misdiagnosis for mental health in terms of getting access to treatment. We often find that folks with mental disorders have treatment that's delayed, or folks just frankly refuse treatment because of the stigma. Folks are suspicious of new treatments and and research is viewed with suspicion, and self-treatment is sought from drugs with abuse potential, or even from prescribing physicians when individuals put pressure on to do it. I just want to note that what we find is that the incidence of mental disorders, substance abuse disorders, fairly consistent around the world. Also, we find consistently in terms of imaging studies, a lot of common abnormalities. We also find that the candidate genes that's been identified for both disorders tend to be overlapped. And we find that in addition to other kinds of supportive treatment, psychological therapies, community type therapies, pharmacotherapy is fairly reliably effective and useful in both disorders. So we're talking about a brain disease and not simply a sociological phenomena or a weak moral fiber. So then we come to barriers towards treatments. On the left, we have medication, we have these drugs that are available in the community that's leading to a lot of community distress. But on the right, we have treatments. We have group and individual psychotherapy. We have various kinds of medication assistant therapy. We have pharmacotherapy. We have community support programs. So there are significant problems in terms of crossing that brick wall between treatment and outcomes. And one of the big problems is that both of them are misdiagnosed. We find that many times mental disorders are not recognized, and also that substance abuse is not recognized as a disorder by many people who are in fact addicted. The good news is that both of them can be treated. The bad news is that both of them are highly stigmatized. They both need to be recognized as being chronic conditions. You don't walk in and say one hit and then it's done. We have no reliable cure for many of these disorders, although various kinds of recovery programs have shown that many times folks do recover, but we don't have a systematic, reliable cure. And we consistently find less accessibility to African Americans. Why do folks take drugs in the first place? Feel good or to feel better. They have the novel feelings, sensation, experiences, and lessen anxiety, fears, depression, and hopelessness. And this is why it's a real issue in terms of the comorbidity of mental health and substance abuse disorders, because folks are using these drugs to produce at least some of the acute symptoms of mental disorders. However, FDA-approved treatments that work reliably often don't make you high. And so folks are much more interested in what they can get off the street that can give them a high, even though it may not treat the underlying disorder itself. Also, many of our treatments don't work immediately. The antidepressants usually take a week or so to actually work. Or they need an adjunct non-medical support for best outcomes. So we can block opioid abuse by giving Narcan and other related issues, but as soon as it wears off, the folks may end up re-addicting themselves. And we've recognized that both substance abuse and mental disorders can be worsened with treatments that come off the street. Even though there's been some research on some of these agents, the general rule is that buyer beware when you use street drugs. And we're finding that even some over-counter agents can make substance abuse and mental disorders worse. And underlying all of this is a great problem of stigma because of misconceptions, misinformation, that the mental illness and substance abuse is a result of personal weakness, a lack of willpower, some sort of moral failing that has nothing to do with what's happening in brain chemistry. And the result is that this stigma will lead to feelings of shame, people reluctant to get treatment, guilt, and isolation from friends and family, or even those who can help them. and leading to symptoms that lead to a decreased quality of life. So what does stigma look like? Well, you shouldn't have kids because you pass it on, or even in substance abuse, you should get sterilized. Everyone has anxiety. You just got to be stronger. Medications are scams. You don't need them. What do you mean you can't get out of bed? It's not like your legs aren't working. Kids and teens can't have mental illness. What do they have to worry about? Mental illness is an excuse to get a life of benefits, or aren't all women a little bit bipolar? And so there's a whole stigma of it's somehow related to a genetic defect. It's not involved in my family. It's a source of shame. The feeling is that mentally ill individuals and substance abusers are somehow more dangerous than the rest of the population. There's general belief that treatment really doesn't work, at least the standardized treatment, so you got to get something off the street. That many folks who are substance abusers are inherently poor, they're immoral, that treatment is a waste of time, that there's poor treatment adherence, that these folks simply aren't going to stick to treatment. And so many folks carry the burden of stigma in terms of trying to deal with these issues. And in addition to that, we had a problem of setting. African Americans disproportionately homeless. Homeless people often cannot get the effective treatments. Incarceration, 50% of all prisoners, African American. Only 17% have access to mental health or substance abuse services. And of that group, only a small number of them have evidence-based treatment. Folks may be seen in a primary care setting rather than a specialty setting. And no matter how good the primary care provider is, they often simply do not have much of the technology we've now recently developed to effectively treat mental health or substance abuse. There's a lack of specialized centers. Many of our mental health clinics do not provide substance abuse services. Many substance abuse services programs do not provide mental health services. Providers often are either not trained, or if trained, they may not be appropriately credentialed so that they can bill for the services. We have regulations that limit availability, substance abuse services. We often have rules in terms of limiting some of the medication-assisted therapy, and Dr. Chapman will say more about this in terms of the appropriate effective doses. But this is also true in mental health treatment. Some agents, such as clozapine, for instance, effective for mental disorders, but limited in terms of the African American community because of rules around the effects that it may have on the blood. There's also a host of financial barriers, both in terms of patients having access to getting appropriate compensation to get treated, or because there's even substantial paperwork issues that are involved, as well as limitations in terms of what the providers can be paid for. We made the point that these disorders occur together, but in all too many cases, a person who's carrying around substance abuse burden, mental illness, simply cannot get treated at the same day by the same provider. And these rules persist despite evidence to the contrary. Also, we have belief that some of the more severe illnesses, more common in African Americans, such as schizophrenia, that these disorders lead to violence. Whenever there's a mass shooting or such incidents, the first question that's asked is, what can we do something about mental disorders rather than the availability of guns, for instance? And in fact, historically, the marketing of some medications was based around being able to deal with violent African Americans. And there's a disproportionate number of folks in the correctional system who are mentally ill or who are substance abusers. Many of those who end up in the correctional systems, well documented, are there because of nonviolent offenders. Many folks simply have unrecognized mental disorders when instead are incarcerated. The The institutionalization program, as we discussed before, is not only it's a good thing getting people out of hospitals that didn't need to be there, but on the other hand, many of them then ended up in the correctional system or on the street. The plan to have the money that's saved from getting rid of large-scale institutions is simply not paid off. The money never gets to the patients. And even in those institutions, not sure that's the best strategy. There's a facility in Petersburg, Virginia recently, in which patients surrounded by correctional officers was literally smothered to death. There's a primary care issue. That is that people with severe depression, often and post-traumatic stress disorder we found, or even stress disorder, bipolar 2, end up in primary care clinics to get help. But unfortunately, many of the primary care providers do not have the instruments to appropriately separate out something such as bipolar 2, which may be made worse by treatments to treat depression. And as a result, they may be treated antidepressants alone and get worse. And most importantly, often are not referred to specialty care. The parity law that was signed was supposed to reduce some of these problems. One problem is that mental disorders do not get the funding and insurance support that you get for general medical conditions. But what has happened is that many insurance providers and others have gotten around this, and as a result, we still have a problem in large deductibles as well as limited insurance coverage for people who have mental disorders and also for substance abuse disorder. What are some of the answers? We found that if folks are going to end up in the correctional system, develop drug courts, which have been shown to be consistently effective, cost effective, as well as outcome effective, but not widely used, especially for African Americans. The other is, of course, in-facility treatment, making sure that substance abuse treatment is existing inside facilities with mental health and substance abuse. Mental health and correctional system for those who have substance abuse problems. Part of the issue is one of will. We got to look at whether or not we want to treat these individuals or we just want to punish them. Punishment, easy to say, politically very acceptable, but in the long run, we found is not cost effective and has lousy outcomes. We got to involve physicians, substance abuse providers, social workers, counselors, psychologists, lay people in terms of addressing these problems, and administrators must be involved as well. Treatment's got to go beyond just pharmacotherapy, even though we have some excellent ones. What we find is that pharmacotherapy in isolation, especially you find someone who's overdosed in the street with opiates, give them Narcan, he wakes up, what happens? Often they do not then get referred to treatment. And what the studies have shown is that these folks end up ultimately again dying of an overdose. Behavioral therapies are available to provide support with the pharmacotherapists, and got to show that we have the medical and social services. I just want to go back to the first slide, again showing that's really a triple diagnosis problem. Folks have general medical conditions, they have homelessness problems, they have housing problems because of the stigma, may not have the access to the community resources to again become effective, productive members of society. There are various organizations that are available: Narcotics Anonymous, Al-Anon, Cocaine Anonymous, the National Alliance of Mental Illness, Depression Bipolar Support Alliance, among others. But we got to bring in our community organizations. What we're finding is that to address problems like opiate abuse, in terms of making available such interventions such as Narcan, we got to get the fraternities and sororities involved, and some have been very effective. We need to have our churches involved, where many of our folks go and get advice and information, and also get the spiritual support so they can address some of their ongoing problems. And we have organizations such as the National Leadership for Healthy Communities locally, which has been got some support to really expand in terms of the churches. It's been very effective in addressing the with the opioid problem, as well as with the AIDS problem, and now we want to expand it to substance abuse. Look at our beauty parlors and our barbershops, and there are several national barbershop organizations that are working to get people to have access to Narcan and other treatments in case something happens. So we got to educate the community about mental disorders. We got to educate substance abuse providers that these are treatable illnesses. These are illnesses that can be treated. And it pays off in the long run in terms of the benefits for society, and they are cost effective. And that in turn to my colleague, Dr. Chapman, that's broke.
Thank you so much, Dr. Lawson. See if we can get Dr. Chapman unmuted. There we go.
Okay, I'm going to share my slides.
If you can unshare, Dr. Lawson.
Got it.
There you go. I know you, Dr. Chapman. You got some background noise, but you can use your outside voice and talk over all of that.
Okay. So thank you very much, Dr. Lawson, for that background information. The last time we spoke 3 weeks ago, I emphasized some of the structural barriers to care that Dr. Lawson has reiterated, including housing and incarceration, or homelessness and incarceration. So with our patient population, my slide is not moving. Let's see. I'm not able to get the, oh, okay. So I wanted to talk about some other essential considerations that are regulatory and specific to our community. We know that substance abuse is common, but treatment is not. And with opioid use disorder, what we know is only 1 out of 10 patients in general receive medication-assisted treatment before they overdose and die. So when we look back at our community, one of the structural problems that we're all very much aware of is the fact that we only account for 5.7% of physicians, 6% of nurses, 4% of psychologists, and 2% of psychiatrists. So we start off with a structural problem in terms of personnel. The other problem is, of course, that post-pandemic, many of our patients are now faced with the possibility of losing Medicaid if they did have insurance. So one of the things that we wanted to look at was the fact that everyone should have access to care. And we know about the structural divide in Medicaid access across the country. Only 38 states accepted Obamacare, including the District of Columbia, and 11 or 12 states still have not accepted that. So we really need to have universal access for treatment, just as we did with HIV/AIDS under Ryan White, where everyone could get medication for treatment. So we need a Ryan White model for opioid treatment. One of those models that we could potentially use was presented by the American Society of Addiction Medicine back in 2018. However, no organization, no state or insurance company actually adopted this model, which, as Dr. Lawson talked about, is an integrated model using medical, psychological, and social services. And of course, we now have a number of practitioners who are trained in addiction medicine, but without having an adequate payment system, we haven't really been able to get the numbers up. But one of the other significant structural barriers relates to the medications themselves specifically. And this is Dr. Helena Hansen. I was on a panel with her 2 years ago for the American Society of Addiction Medicine, and she's advocated for over 20 years the fact that buprenorphine, one of the 3 major medications, FDA medications approved for opioid use disorder, was systematically not marketed to the African American community. And that was a concern that because it was a Schedule III drug, that it would be diverted in our communities and subsequently have the same restrictions as methadone and become a Schedule II drug. And she demonstrated this in New York. So we know that areas with higher income are more likely to have access to buprenorphine, and poor areas not have access to buprenorphine. And this is a study done out of the University of Michigan that showed that only 2.7% of prescriptions for buprenorphine were actually given to African Americans. The other problem is dosing. We know starting in about 2014, 2015, we started seeing synthetics added to the heroin, the street heroin drug supply. And as Dr. Edwin Sawitz points out, that as these more potent opioids were added, that methadone, even up to 200 milligrams, or buprenorphine up to 24 milligrams, patients were still breaking through. We did a study at Howard University when Dr. Lawson was there, showing that our patient population, which is an urban African-American population, actually did better with higher doses above 24 milligrams. But unfortunately, many of the insurance companies and state regulators have not acquiesced to this need. And this chart, this is an old chart from 2015, but it actually shows how buprenorphine dosing varied from 8 milligrams to 32 milligrams across the country, depending on what state you're in. Now, Vermont, New Jersey, the state of Washington, all allow dosing up to 32 milligrams. And these are some of the prior authorization forms that we have to fill out or with the insurance companies to get approval for doses up to 32 milligrams. But one of the concerns was always that patients just wanted higher doses so that they could sell the excess. But if we look at during COVID, the 2 graphs on the left-hand side actually show that in spite of the increase in overdoses during COVID, that there was no increase in buprenorphine found in autopsy toxicology screens in patients, and it remained at about 2%. So buprenorphine was not being diverted on the street. And we again show that in the District of Columbia. On the right-hand side, you can see the marked increase from 83 overdose deaths in 2014 to now 448, which is a 500% increase. 96% of our patients have fentanyl in their system, but there was actually a decrease in buprenorphine and a decrease in methadone at autopsy data. This is an email to me from the Legislative Council of the American Medical Association, again commenting that the American Medical Association wants removal of prior authorizations for these medications and dosing caps. So again, when we look at naloxone, we have the same issue. Now that we have these stronger synthetics penetrating the market, we find that it takes higher doses of Narcan to reverse those. And Dr. Salwitz actually described a study where half the patients, 42% of the patients who overdosed and died at autopsy, only 42% of them had norfentanyl or the metabolite of fentanyl in their system, meaning that they died in less than 2 to 3 minutes, less than 2 to 3 minutes. And you can see this on this slide where you see heroin and then fentanyl, that with heroin, you have 20 to 30 minutes for respiratory depression, 15 to 60 minutes for non-responsiveness, and cardiac arrest, 30 to 90 minutes. But look at fentanyl, 0 to 2 minutes, 1 to 5 minutes for non-responsiveness, and 5 to 10 minutes for cardiac arrest. Very much different. We can, this slide just shows 3 patients that we resuscitated in my office on separate occasions in 2022 that required 6 doses of 4 milligram Narcan. So we now know that the FDA 2 years ago approved 8 milligram dosage, but still the predominant dosage is 4 milligrams in dual pack. So you can see that if people were walking around with 8 milligrams at the most, that there are going to be some patients that they're not going to be able to resuscitate. Again, this slide is just a model showing that the higher the percentage of fentanyl in your drug supply, the more pessimistic are your ability to save people. So at 99% on the right-hand side, you can see that the District of Columbia is very close to that number. And it requires that you have more naloxone kits, more providers giving buprenorphine, et cetera, in order to reverse that trend. Again, this slide simply shows what the District of Columbia looks like from 2014 to the present, with a rapid increase in overdose deaths. You can now see on the right-hand side, that little green sliver shows the impact of Narcan as opposed to the excess deaths that we're now experiencing. So my recommendation at this point is that we, of course, have in prior authorization, have higher doses of buprenorphine above 24 milligrams, and maybe even higher than 32 milligrams in some cases, and of course, increase naloxone availability. So now we have, even beyond fentanyl, additional narcotics or opioids, the nitazines, which some people say are 4 to 5 times more potent than fentanyl. And of course, xylazine, which is not a narcotic, but it's an animal tranquilizer, is now found in many toxicology screens. This is a tox screen that I did. I had an outside lab do 5 of my patients, and one of the patients came back with xylazine and designer opioids. So we know that these medications or these poisons are in the drug supply in the District of Columbia. This is an article that just came out. It has not been published in hard copy, but it shows really the impact of xylazine, which started in about 2018, and you can see the rapid increase in impact and overdose deaths in our drug supply. So xylazine has complicated our ability to have effective use of Narcan, and it's also impacted the effectiveness of buprenorphine, even though it's not a narcotic, but it works synergistically with fentanyl. So one of the things that we've advocated in order to increase the availability of treatment are incentive payments for patients. And this is a study that was done in California on patients who were suffering from stimulant disorder, and it actually showed that paying patients to go into treatment actually save money and also save lives. So the idea or the theory is perhaps we could invoke a similar methodology using incentives for not only patients, but also for pharmacists and pharmacies that are also reluctant to treat, and also providers. And this is a study out of Rhode Island that actually did this using pharmacies and an incentive payment plan as a pilot demonstration. So when we look at the overall cost of criminal activity, healthcare costs, and lost productivity, those numbers appear to be, this is from Pew, $142 billion. If there are 21 million people, that accounts for about $68,000 in costs per patient. So treatment actually saves money, both from a medical standpoint with any chronic disease, costs or about 4 times more, whether it's asthma, congestive heart failure, diabetes, or hypertension. So that if we actually use an incentive payment plan for patients, providers, and pharmacists, that we could actually save about $48,000 per patient, even if the total cost per patient in treatment was $20,000. So finally, I just want to mention that Howard University is one of several institutions, the School of Pharmacy, that has received money from FOR. FOR is the Foundation for Opioid Response Efforts to actually investigate a pilot demonstration where they're going to use 80 pharmacists for educational purposes and create a pharmacy physician peer recovery coach collaborative model for treatment. So I'm going to stop there.
Well, thank you so much, Dr. Chapman and Dr. Lawson. We're going to open the floor for questions, but first I'm going to ask the first question. Does this seem to be a targeting of Black communities for not only opioids, but ones that are laced with the fentanyl and the other substances to create untreatable cases?
Dr. Maxey, I think you've once again hit the nail on the head. The District of Columbia, of course, obviously is the nation's capital, and you can see the rapid increase in overdose deaths in the District of Columbia, and all of these additives were put into our drug supply. And of course, the District of Columbia is 46% African American. So I think what you just described is applicable to virtually every urban market in this country.
Dr. Walks?
Let me add my thank you to yours, Dr. Maxey. Thank you, Dr. Lawson. Thank you, Dr. Chapman. As we look at not only the policy challenges that you've raised, but the stigma challenges, my comment, and I think it's a comment and a question, goes to the non-medical, the non-science components of substance use disorder and mental health challenges. We treat medical conditions kind of with a typical medical model, right? So somebody comes in and they have high blood pressure, right? Hypertension. We will look at things like diet, things like their community resources and what have you. And typically we won't just give them a pill and send them away. We'll say, I want you to do this or that, and this kind of therapist and that kind of therapist. And so it's a more comprehensive treatment approach. And I think it's similarly comprehensive for us to effectively treat mental health, substance use disorder. And so maybe if one of you or both of you could say a little bit about, why don't we do that? Why don't we just talk about this like if it's another medical condition that requires an integrated approach like we do for, pick one, thyroid disease, diabetes, hypertension, bipolar disorder, substance use disorder. We can approach people with this same sort of normal integrated approach. We want to look at, what's the first question they asked us in medical school? The first answer is take a good history. Take a comprehensive history, find out all of the impacting factors. So I wanted to know if you all could say how you feel about that and how you integrate that into the work that you do.
Well, I think that this is an excellent point that you made. There's a lot of, what's interesting is there's a lot of verbiage about folks recognizing that. But what I've been impressed with is that this message is not being delivered significantly to the African-American community. American Psychiatric Association pushing what we call integrated care models, the American Medical Association pushing training programs for integrated care. The Veterans Administration has a large integrated care initiative. But yet when you actually look at implementation, what's missing is the politics of it. I think we now have individuals, people of color in political positions, in positions which, in folks who are on our communications train. We need to work with them to get the message out, Unfortunately, the message that's still being persistent in our community, and that's why we're working with such groups as Leadership for Healthy Communities to work with the churches. That's why we're working out with the barbershops, to work out with these shopping centers to see if we can get a grassroots level, a change in which the way in which we are dealing with these issues, a recognition that rather than treating these as some sort of mystical kind of disorder, to recognize that these are brain diseases. We do this with such disorders as seizure disorders. We've gotten the word out about Alzheimer's. We've gotten the word out about a number of different disorders. But when you start talking about substance abuse and you start talking about mental disorders, and when you start talking about them together, what we still find is the stigma, even among our providers, who say we don't want to deal with these patients because they can't get better. There's something morally wrong with them. There's something that's intrinsic in terms of what's the matter with them. We do not want them in our side of the fence.
I have a follow-on question for you two gentlemen. One, is there a treatment for the xylazine addiction or overdose? And two, we've talked, Dr. Lawson, recently about transcranial magnetic stimulation. Is that something of interest to treating substance abuse?
PMS doesn't work very well for substance abuse. They're pushing to get it for cocaine use as a treatment. And I know of several centers that's doing it, but I just saw a patient who just had TMS for cocaine. Didn't work. Not to say it can't work. I think there's a lot of work that needs to be done to make sure it's available. But the bottom line is that TMS simply isn't available in many African-American communities. We can talk about this in other more exotic treatments, but there's a lot of evidence-based treatment that people of color simply do not have access to. No, I don't know of any in the DC area and in mental health clinics. that actually can does offer TMS. It's most of the university centers, Howard, George Washington, others, but it's not available in mental health clinics. And so I think it's well worth exploring. I'm working with a group which we're going to be starting to do this. What we do know is that TMS does treat mental disorders, and it may be another very effective way. It's not as effective as anticonvulsant therapy, but it's more effective than medication and talk therapy to be able to treat people with unremitting depression, anxiety, post-traumatic stress disorder, which normally for these folks they may have turned to street drugs to try to deal with their problems. So we do know that it does work for those, and we can treat the underlying mental disorders. Maybe we can get some traction in terms of doing more.
Dr. Chapman?
Yes, I was just going to go back to the previous question about better ways of treatment. We do know that telehealth and telemedicine works. Dr. Lawson and I really, that's how I went back to Howard when Dr. Lawson was chair of psychiatry, because my office is 2 miles from any other medical center. And I'm not a psychiatrist, but I know that these patients needed psychiatric support. So we developed a telehealth, an urban telehealth system, which at the time was thought to only be apropos for rural areas, showing that our patients catching 3 buses and dragging 2 kids along is a burden and interferes with patient compliance. So we created that model, but now the issue is getting payment in a collaborative way. And we think that bundle payments would be the way to go. I showed you the 68,000 versus 20,000 per patient. $20,000 would go a long way in treating these patients, both primary care, mental health, and substance abuse. When you have that patient in an office setting, you can bring all of those support services in without moving the patient.
Yeah, I want to just reinforce what Dr. Chapman is saying. I have telemedicine practice that's in 4 states. Very effective in terms of reaching out to our community for folks who otherwise would not be getting mental health treatment. The problem is, and I'll say it bluntly, MD Live, Teledoc, they don't provide significant substance abuse services, and they actually do not utilize medication assisted therapy. We're trying to convince them to do it, but there's we run into the restrictions in terms of using opiate-related substances across state lines, and we run into the ongoing problem of trying to convince the risk-averse people in these programs that somehow you start offering this, that's going to become a source for more people becoming addicted. So a lot of it's the belief system that buprenorphine is going to produce a bunch of addicts, that Narcan, and many of you may know we now have Narcan almost available for over the counter, but it's not going to be free. They're targeting $50, but some of the folks aren't going to be able to get it together to take $50 to take something that's going to make them give up a drug that makes them feel good. So again, we got the treatment, we got the pieces, we got a better mousetrap, but we got to get the political will, just like we're getting the political will for a lot of other things. We got to get the political will to be able to address this problem that's killing more people than a number of other problems in our community that we're putting much more resources into dealing with.
Thank you. Dr. Walters, anything in the chat?
Let me, while we're looking in the chat, or if Dr. Neighbor Stevens can look in the chat for us, Dr. Maxey, I'm still trying to wrap my head around something I think I heard Dr. Chapman say a little bit ago. Dr. Chapman, did you say a 500% increase?
We
Did I
had
hear you use those words?
we had 83 heroin overdose deaths in 2014. We now had in 2022, 448. And they were mostly 96% fentanyl. One of the things that I want to point out is we don't even test for xylazine. We don't test for these designer drugs. So we don't know what else is in the drug supply. And that's why I did those 5 random patients a month ago, just to see, because, you know, you have these companies coming in, these labs coming in, saying that they have a better mousetrap. So I said, let me see what you have. And this particular company did provide screening for xylazine and some of the designer opioids. And 1 out of 5 patients did show up out of the 200 patients that I treat every month.
So there is a comment in the chat related to what we were just talking about. And I think the question in the chat is about the epicenter of the opioid epidemic and the concern about the xylazine and the open sores that develop and what have you. That's what's in the chat. I don't know, Dr. Chapman, do you feel that this problem is a bigger problem than just Washington, D.C. or Philadelphia? Should we be concerned when the news tells us this is where the problem is? Or should we accept that the problem is not going to be held in any one zip code and it's going to be a problem we all have to be particularly sensitive to?
Yeah, this problem is changing every day. 3 weeks ago, I showed you a slide that actually showed that the fentanyl epidemic predominantly was in the Northeast initially, but now it's spreading across the country. That's in the so-called street drug market. But now, of course, the cartels are looking for new markets, and they're now lacing pills, Adderall, benzodiazepines, as well as some of the opioid products have fentanyl in them. And that's targeting a younger market for the most part. Children or kids who go on the internet and get access to these medications. And so now we're seeing an uptick in young folks under 20 who are overdosing on what are considered to be party pills.
Yeah, I just want to add to Dr. Chapman's point. I don't think many are aware that DC, by the way, is number 2 in the country in terms of amputation rates. So a lot of that's related to diabetes and so forth, but this is just be another factor that can play a role in this. And also now we're beginning warnings that Benadryl is being used as a drug of abuse. And I'm sure there's going to be some xylazine in combination with that as young people look at other ways of getting high.
Let me ask, we're getting to the top of, way past our time, but I have a great concern. I was listening to a testimony at Congress a few weeks ago, and there was a lady complaining about the drug lords that are putting these drugs in our community. What can we do to stop our young people from trying out drugs, even if they don't know? Why would you take a friend's pill or a pill from anybody? What can we do about that, preventative wise?
I think one thing that I've done is I've made a point of calling in on some of our talk radio shows, which is encouraging folks to do all kinds of stuff. Also, we need to get our word out on TikTok. Folks talk about the bad news. It is the bottom line is also a wonderful opportunity to reach out to young folks to get the word out to deal with some of these issues. So part of it is that we need to get involved in our local communities, use our influence as physicians to be able to let folks know that there are alternatives to deal with their problems other than street drugs and other than drugs that they have no idea what the long-term consequences are.
So Dr. Lawson, I didn't know you were a TikTok influencer. I'm gonna have to look you up. Dr. Maxey, Miss Joanne Russell has had her hand up for several minutes now.
Ms. Russell?
Simon, can we help Miss Russell get, there we go. Go ahead, ma'am. Thank you.
And I am so glad I joined today. And Dr. Maxey, I had sent my chat text to you. I was asking, how can we get a presentation? This is so timely. I belong to a collective of community clinics, churches, and nonprofits. And we have been discussing the epidemic. We are in Los Angeles, so our education committee brought it because our kids are dying in the schools. We have our collective includes King.
Miss Russell, your voice has faded. We can't really hear you now.
I said our collective. Can you hear me?
All right,
now?
Miss Russell?
Yes.
It sounds like you either moved away from the microphone or something happened with the connection. I'm going to say on behalf of Dr. Maxey, since you're in Los Angeles, if you reach out to Dr. Maxey, he knows everybody, and he can certainly help with pointing you in the right direction.
Let me give her my email, randall.maxey02@gmail.com. And the phone you can contact me on is 310-686-8490. And Simon, make sure I get her chat thing. Are there a few more comments or questions?
There's another hand up, Dr. Maxey. Shira Arrington.
Okay.
Hello,
ahead, ma'am.
everyone. How are you?
Hi.
Good. First of all, I want to thank each and every one of you for this amazing information regarding addiction. But my thing is kind of the reverse. I am a person living with sickle cell at the age of 60. Thank God, thank goodness.
Yes.
However, when I'm in the hospital in a medical setting and I'm giving opioids, which is mostly Dilaudid, to combat the excruciating pain that I feel. But it seems like as a Black woman in a hospital, I have to literally beg and plead with the physicians to either increase my Dilaudid to relieve the pain or give it to me in more stable intervals to help me, because I'm literally screaming when I'm having a sickle cell crisis. So I know that disparity, of course, is, they're reluctant to give Black people the pain meds, but even in a hospital setting when it's controlled. And then when I release from the hospital, they do give me Dilaudid, and they also give me the 4 milligram of Narcan. Yeah, the Narcan. And I'm so reluctant not to even use it at home because of the information I read, but by the grace of God, my life expectancy was 35. I'm now 60 going on 61. So God is good. So thank you.
That is good.
Yes, all of the information. And I appreciate you guys taking this profession and helping those that are in need regarding, the drugs. And I pray that our young people will steer away from that. And I really appreciate all the pertinent information that I have ever received from the Health Trust. And thank God for Dr. Sherrod, who always shares vital information. She's like an independent directory as well. So thank you guys so much. And I appreciate you. And God bless you and have a wonderful day. Thank you.
Thank you.
Thank
Maybe
you so
Dr.
much.
Chapman, you can address that question. Thank you so much.
Yes, of course, this is a common problem that we faced throughout my medical career here in Washington. Howard University, of course, has had a sickle cell center for decades, and we're very much aware of the fact that that is a legitimate use of opioid medication. And as a matter of fact, the president of Howard University, if you don't know, also is a survivor of sickle cell disease. So we advocate for patients who need their medication to get their medication. That's not being abusive at all.
And I just want to add that we actually studied how it found that the depression rate among individuals with sickle cell is higher than the general population. And a lot of it because of lack of access to effective pain-reducing medications. And we're also finding the same thing among our elderly citizens. So we're not saying throw away opioids. By all means, let's see that we can get opioids available for those who need them and for those who find them effective in terms of dealing with pain. We have to address this belief, especially among my white colleagues, that Black people are somehow immune to pain. We are not, and we do benefit from these agents.
There's one more comment I'd like to make. When I was doing hospital medicine, we found that patients who had the little push button and were able to self-medicate during crisis in a hospital tended to use less than normal. Is that correct? Dr. Chapman, Dr. Lawson?
I think that's correct, because there's probably less anxiety because the patients know that they're going to be able to get relief, and early relief, again, probably lowers anxiety and depression.
Yes.
Okay. Well, I appreciate you gentlemen giving your presentation today. It's been well received and a lot of good information. I'd like to have final words from Dr. Lawson and Dr. Chapman, Dr. Walks, and myself. I think Dr. Neighbor had to drop off.
Well, I think the key point is that we're talking about treatable. We have the technology to apply it to these treatable conditions. We don't have to make punitive systems. We need to make sure that people get treatment in settings that are comprehensive, not simply given the medication, but also given the social support that's needed, as well as the community support that we can bring to bear for folks to address these chronic problems.
And I think, again, the ideal treatment setting is going to be a collaborative model, an integrated model, using the technology that we now know works, including telehealth and all of those parameters, and also connecting this network with pharmacists and pharmacies that are willing to provide the medication. There are far more pharmacies or available pharmacies close to where patients live. And we prescribe our medications electronically now. So there's no reason why we can't make these medications easily available for our patients.
Thank you so much, Dr. Chapman and Dr. Lawson. Dr. Walsh, final words?
I wanted to underscore something that Dr. Lawson and Dr. Chapman mentioned with respect to drug cartels and others putting additional things into pills. No one wants to kill their customer. They want you to come back and buy another whatever, another organic tomato, another car, another suit. They don't want you to take their drugs and die. The problem is people are adding things, and then at the next step, somebody else says, well, I'm going to make mine a little bit better, so you'll come and buy mine instead of theirs. And so when I have a patient say something to me like, well, I know that what I took was safe because I got it from my friend so-and-so. Well, where'd they get it? Well, they got it from their brother. Well, where did they get it? And the answer at some point very soon in that conversation is, you don't know who made that. You don't know who put that together. They didn't intend to kill you, but the amounts of fentanyl and these other medications that will kill you, we can't even see. It's such a tiny amount sometimes. And so my comment is, if you know someone that is using these drugs for whatever reason, and Dr. Lawson and Dr. Chapman gave us a lot of reasons why. People aren't necessarily trying to commit suicide when they overdose. They're trying to treat their depression. They're trying to treat their anxiety. They're trying to treat something. They're trying to treat the fact that they just lost their job. They're trying to treat the fact that their relationship just broke up. So it's not okay when someone says, well, I just take enough to do whatever. I just take enough to feel better. I just take enough to get to sleep. You don't know what you're taking. And that's part of this problem. People are not necessarily trying to harm themselves. They just are, because the drugs are just so dangerous. Thank you, Dr. Maxey.
Thank you, Dr. Walks. I want to remind everybody to visit their primary care physician. Those are the watchwords of Dr. Wilbert Jordan, our departed brother, our fallen great tree. Thank you, everybody, for attendance today. Thank you, Simon. Thank you, Dr. Walks, Dr. Chapman, Dr. Lawson. Have a great Sunday.
Dr. Maxey,
Yes.
since we have Pastor Pointer, can he pray us out this afternoon?
Yes, Dr. Walks. Dr. Pointer, please pray us out. Or I should say, pray for us at the end of our session.
I know we have not muted the pastor. There's just so much wrong with that. I can't even believe it. I didn't think that was possible, Pastor Pointer. Simon, can we please unmute Pastor Pointer?
Thank
ahead,
you.
sir.
I appreciate you, Simon. One thing I want to share with you, there is a note of celebration. C. Lamont Gibson, who we share the steering committee with, his brother received a successful kidney transplant surgery
Great.
earlier today. So
Wonderful.
let's give thanks. Let us then look to the Lord. Lord, our Master, how majestic your name in all the world, whose splendor was told over the heavens. Again, we bow humbly before you, God, to say thank you. Thank you for your servants, Dr. Lawson and Dr. Chapman, and for their work. But thank you, oh God, for them coming to us and sharing with us these multitudinous challenges. But we are not undaunted. We know that you are the all-wise. We know that you are setting our hands to work that we are capable of doing. So we thank you again, oh God, for the life of your servant, Wilbert Jordan, and for his sojourning among us. We acknowledge that you are the wise one, and so we know you don't make mistakes. So we simply tell you, oh God, that he was the best of us. May we endeavor to serve with the kind of fervor that he served. May we, in every breath, give our lives to the glory of your great name. And as we leave this place today, we ask for your accompaniment, that you would keep us, direct us, guide us, and bring us, if it is your will, back to this place on next Sunday. And we'll be careful to honor, praise, and thank you forever. In Jesus' name, amen.
Amen.
Bless you, my friends and colleagues.
Thank you, Pastor. There'll be a memorial service for Dr. Jordan on the 28th from 4 o'clock to 7, I think, at Drew University. And you're all invited to attend that. Have a great day. Thank you, Simon.
Thank you, Simon.